Hello everybody, thank you very much for coming back on time. We are going to shift gears now and talk about another state, which is the state of biochemical recurrence. Where does biochemical recurrence fall? So we've already talked about suspected cancer, but when you have localized cancer, we broadly categorize patients into low risk, intermediate risk, and high risk. High risk locally advanced is considered APC, advanced prostate cancer. So it falls into this category here. These are all the states that are said to are called advanced prostate cancer. Biochemical recurrence is not advanced prostate cancer. It's this state here, and it occurs in patients who have localized prostate cancer, could be high risk, that's been surgically treated, or mostly intermediate risk cancers where the PSA comes back. So this is the state of biochemical recurrence. There is a big difference between biochemical recurrence and biochemical failure. And you need to realize that these are distinct terms. So biochemical recurrence is increasing PSA levels after a curative monotherapy. Curative monotherapy. Radiotherapy or surgery or ablation. Yeah? So most of these men have no metastases. Most of these men have normal testosterone levels. So they're called castration naive, or also called hormone sensitive. Right? Most of them, as I said, have normal levels of testosterone, and the intent is to cure these patients. Very different from a rise in PSA in somebody who has metastatic disease and is being treated with some other treatment. So biochemical failure is increasing PSA on androgen deprivation, on castration, for castration-resistant disease. So it's a different state. And when you use your words in your dictation, remember, difference, castration, biochemical recurrence and biochemical failure. Okay. So how do you define biochemical recurrence? Biochemical recurrence, according to the EAU or the AAU, is a PSA greater than 0.2, measured at least 13 weeks after prostatectomy, with a confirmatory test showing a persistent elevation greater than 0.2. That is the definition. Post-radiotherapy, it's a different definition. Here, it is 2 nanograms ml above a nadir of PSA. So you follow the PSA, it comes down, and then it starts to rise, and it must be more than 2 nanograms of increase. Okay, so there are different definitions post-prostatectomy and post-radiotherapy. Now, what you have to remember is that this is very common. About 1/3 of patients. Well, 1/3 of patients with biochemical recurrence, all these patients don't die. They don't die. Some of them do die, but not all of them. And this is the important thing to remember. So, not all biochemical patients develop harm. What is harm? Local progression, metastasis, death, right? And it turns out that if you have a high Gleason score, or the doubling time is very quick, then those patients are more likely to develop harms. But harms don't come tomorrow. They don't come next year. On average, it takes 6 to 7 years after the prostatectomy when they start to progress clinically. So it can be a long time. Okay. Now, it is possible to salvage these patients, but the benefit is only in those patients who have something called high-risk biochemical recurrence. If you have low-risk biochemical recurrence, there's probably not even necessary to treat them. But high-risk biochemical recurrence, it is necessary to treat them. The important thing to remember is don't give androgen deprivation too quickly. Patients are incredibly anxious because their PSA is going up. They are extremely anxious. They want ADT. You give them ADT, it's the worst thing in the world for them. Because although the PSA will go down, surely, but they will not benefit from that intervention. They will not benefit from that intervention, and they will get multiple harms, which we will talk about in a few minutes. So, how do you define high-risk biochemical recurrence? Now, this is important for you to know because your test will be positive in high-risk biochemical recurrence, it will be negative in low-risk biochemical recurrence. So it's worth you knowing this. So this is the EAU high-risk definition. So if you are high risk is having a ISUP 4 or 5, right? Now what did we say? Intermediate risk prostate cancer was anything ISUP greater than 2, right? 2 or greater. Here, look, it's 4 or 5. And you have a doubling time of less than 1 year. And remember, these are the people where it is possible to salvage them. So you are looking for recurrences in patients with high-risk biochemical recurrence. Now here are the survival curves. On the left, metastasis-free survival. On the right, cancer-specific survival in low risk and high risk. You see, in low risk, right, you can see most patients haven't developed metastases, you'll see here, out to 120 months. Right? That's almost 10 years out. With high-risk disease, you can see a lot of patients are developing metastases or are incurring mortality as a result of it. So you need to look at those patients who have high-risk biochemical recurrence. So, what are the clinical priorities? Remember, for post-prostatectomy, there is almost no role for imaging because most patients should be treated before the PSA reaches 0.5. 0.5. So the threshold to treat is 0.5. Your sensitivity at a PSA less than 0.5 is almost 0. Believe it or not, it's poor. Okay. Above that level, your role increases. So, post-prostatectomy, they are going to give pelvic radiotherapy anyway. Your job is only one job. Is there any disease outside the true pelvis? That is what your job is. So the clinical priority is to rule out systemic recurrence, much more important than rule in local recurrence. So you should be doing systemic restaging, not local restaging. Now, salvage treatment after radiotherapy is completely different. It's completely different. Because the majority of the recurrences are in the prostate gland. But salvage is very expensive. It is highly morbid. You cannot do salvage unless you can find the lesion and prove that it is recurrent cancer. That changes your job. Your job is to rule in recurrence as well as rule out distant metastases. So your job changes. Your job changes. So post-prostatectomy, your job is to look outside the pelvis. Post-radiotherapy, your job is to look outside and inside the pelvis. And that is important to remember. Okay, so the clinical needs, therefore, okay, is to risk stratify patients. Is this low risk or is this high risk? Okay, you need to find where is the recurrence. Do I go biopsy it or do I not biopsy it? Do I have to do that? Is to detect metastases in the pelvis or outside the pelvis. Many clinical needs. Okay. There's a big issue about just starting treatment. His PSA is going up. Why don't we just get on with it? Just give him ADT. He'll go away for 2 or 3 years, right? It's a bad idea. Why is it a bad idea? Because there are multiple radical options you could use to cure that patient. By giving ADT, you induce castration resistance. And that's a really bad idea because you take a disease that you could cure and you turn it into something that you won't cure. Number one. Number two, you give him multiple side effects. Osteoporosis, metabolic syndrome, sexual dysfunction. 3, yes, he leaves your office, doesn't bother you, but he does not get a survival benefit. There is no survival benefit to giving early ADT. It's never been shown. So there are multiple reasons why you shouldn't start ADT too early. So your job then, is to provide an algorithmic approach to advise your clinicians. Okay, so your clinicians will always ask you, the first question they'll ask you is, should I do a prostate MRI or should I do a PSMA scan, right? Every one of us had these questions. What should I do? You need to know the clinical priorities, right? Is it to rule in recurrence or is it to rule out systemic recurrence? What should you choose? That depends on the primary treatment. Depends on the primary treatment. So if you had a multimodal treatment, prostatectomy followed by radiotherapy, now the PSA is going up. The chance of it being in the prostate gland is low. Prostatectomy, post-op radiotherapy already given, now the PSA starts to go up. The chance of it being in the prostate are 0, because you've already sterilized the bed, right? For example. So it depends on what was the primary therapy, and it depends on the PSA doubling time. How quickly is the PSA doubling? If it's doubling less than 6 months, surely it's metastatic. If it's more than a year, it's going to be in the pelvis. So where you look depends on the clinical factors. Now, for local disease, what should you use? For local disease, you should use multi-parametric MRI. There's no doubt about it, and contrast enhancement is mandatory. Contrast enhancement is mandatory. We know that we are better than Choline-PET scans, for example, and there are real issues with using PSMA or using Choline-PET scans and bladder accumulation. That's why MRI wins every single time for local disease. And here's an example of a large recurrence which was hidden by the presence of contrast medium within the bladder. But it's easy to see on the multiparametric MRI. There it is. Okay, now, For lymph nodes, imaging, morphological imaging, as you all know, is no good at all. Why? Because we use morphological criteria and we know we are not good. Yeah, we are not good. Okay. So, if you are interested in lymph nodes, then you need a super sensitive technique, a next generation imaging technology, and the most sensitive is PSMA PET scans. Right? Followed by choline or fluciclovine scans. In terms of availability, however, PSMA PET is not that available depending on where you are. I can get 2 doses every 2 weeks in my center. 2 doses every 2 weeks. Choline I can get every day. So, although one technique is more sensitive, availability is an issue. Okay. So, here's an example of how PSMA is more sensitive than choline PET scan. So here is a choline PET scan, and here is a PSMA. You can see there's a lot of background activity on the choline PET scans in the bone marrow, in the liver, pancreas, for example, and here's the PSMA scan. So you can see this lesion here, and this lesion here is much more difficult to see, whereas on a side view you see there and there. Now there is a difference in time, I grant you, but this background increase decreases the sensitivity of the choline PET scan. The interesting thing is, on imaging, we would have seen that lesion on the imaging, but this lesion here, all of us would have called normal. So we can't see microscopic disease. PSMA PET sensitivity does depend on the PSA level. So here's the PSA level, and you can see when the PSA level is 0.1 or below, it's 60 to 70% of patients will be positive. This is much better than choline. Much, much better than choline. Okay, so PSMA is the best technology. So what do the guidelines say? Now, the guidelines are quite interesting if you read it this way, and these are the 2019 guidelines. So essentially it says PSA recurrence after prostatectomy and PSA recurrence after radiotherapy. So let's look at prostatectomy. You'll notice it says PSMA and PSMA. So the first thing it recommends is PSMA. The second thing it recommends is PSMA if it's not available. So it's saying use PSMA. But it says do systemic staging first before local staging. If you look after radiotherapy, it says the first thing is perform a MRI of the prostate. Remember, that's what we said before. After radiotherapy, rule in local disease is as important as rule out metastatic disease. Right? So you can see the first thing it says is do an MRI of the prostate. And this is reflected in the guideline. The second thing it says is use PSMA. If PSA is not available, use choline, which is as good as fluciclovine. Fluciclovine or FACBC is now a commercially licensed product. But PSMA is more sensitive. So, this is the algorithmic approach that you should use. Test for biochemical recurrence. Decide which is more important depending on the status and on the clinical priority. We will often do a whole body MRI before a PET scan. Why? One, whole body MRI is cheap, cheerful, and it's very easy to get, and I do 7 cases a day. So I can do that, and if I see metastatic disease, I'm finished. I can only get 2 doses of PSMA a week. No, 2 doses every 2 weeks, right? Whereas I can do a whole body MRI every day. That's number one. So I do this first, and if I don't see anything, then I may go to a PET scan afterwards. Okay, so what is this whole body MRI stuff? We're going to be talking about whole body MRI in much more detail tomorrow. But if you look at the ability of whole body MRI scans to detect metastatic bone disease, not lymph nodes, bone disease, you'll notice that choline is here, whole body MRI here, and this is bone scans. Right? So bone scans, not that great. The guidelines say bone scans, right? Many guidelines say bone scans, but actually not so good. So let's put that all together. When the PSA is above 0.2 post-prostatectomy, but it's not more than 1, 0.2 to 1, right? PSMA PET CT is what is recommended by the EAU. If it's greater than 1, if PSMA is not available, then fluciclovine or choline-PET scans. If PSMA is greater than 10, if the PSA is greater than 10, then you know what? Fluciclovine, choline, whole body MRI are all equally good. If it's more than 20, you can use bone scans if you want, right? Because the chance of the metastatic disease being there is very high indeed. Okay, so here's an example of a whole body MRI and a fluorocholine PET scan in somebody who has a metastasis in the sternum. You can see the information is identical. Here's somebody with a fluorocholine PET scan who actually has a metastasis here, wasn't called prospectively. Here's the whole body MRI scan, was called prospectively. And you can see that there it is on the diffusion weighted sequence. That's what it looks like on the choline PET scan. Okay, so in this particular instance, for that particular bone, it turned out that diffusion imaging was better. But lymph nodes are a problem. Okay, so here is a lymph node that was not called prospectively. Okay, that lymph node was not called prospectively, but this PET scan was called prospectively. So for lymph nodes, whole body MRI is not going to be great. In fact, choline is going to be better, a next generation imaging technology. Let's take one patient. So this guy has high-risk prostate cancer, T3B disease, right? Seminal vesicle invasion, Gleason 8, lymph node positivity, has a prostatectomy, followed by pelvic radiotherapy. So he's high risk, he got pelvic radiotherapy straight away. And here is his field. Can you see that? So radiation atrophy here, no radiation atrophy there. Look at his recurrence. Just above the radiotherapy field, right? All of you have seen cases like that. Okay, so there it is on the whole body DWI. Here it is on the CT scan. You can see it on everything. Okay, now we localize that and we treat it with CyberKnife. So here's the radiation field. We treated it, and you know what? The bright dot disappeared. Okay, and his PSA came down. So it went down from 6.1 to 0.7. You'll notice it isn't 0. If he was cured, it would be 0. So he still has cancer. Okay. Then look what happens to him. His PSA starts to climb. Can you see that? And here it's 4.7. This is the whole body MRI scan showing 2 dots, 1, 2. That is the choline PET scan, positive. Okay, so what should we do? We treated it. So here's the original lesion. You see how it went away. But this lesion here, which was impossible to see before, grows. This lesion here also grows. Now what do we do? Treat again with CyberKnife? Okay, that's what we did. So CyberKnife number 2. First one left side, now 2 on the right side. Okay. Then look what happens to the PSA. It goes up from 0.2 to 0.6. Okay? We found the lesion, here it is, on the Choline-PET scan. There it is. Okay? We treated that again. And the PSA comes down, so there's the lesion there, there's the Choline-PET scan, so the patient got better. PSA goes down again, and the PSA comes back up again. Okay, now who can see the recurrence? The recurrence is here. So exam 1, 2, and 3, here are the dates, 16, 17, 18. Okay, here is the recurrence, see that? Okay, there it is, there. And what did we do? We treated it again. Okay, so he had in total, he went 6 years since biochemical recurrence, no ADT. He had 3 CyberKnives to 5 lesions. And then look what happened in February 2019. His PSA is 0.2, and now he's developed metastatic pancreatic cancer. So he went for 6, 7 years just with focal therapies, no androgen deprivation. So the whole idea of finding oligometastatic disease is to postpone the onset of androgen deprivation for as long as possible. So this method of dealing with oligometastatic disease, 3 or fewer metastatic disease, is now becoming into quite a vogue. So you can see this was published in the Lancet this year. Yeah? And you can see, compared to standard of care, if you look at overall survival or progression-free survival, you can see that if you use CyberKnife radiotherapy, after about 1.5 years, you do begin to see a separation. So patients are benefiting not only from the postponement of the androgen deprivation, but they are also beginning to live longer without hormonal therapy. Okay, so some of your urologists would be very interested in this kind of work. So, here are the take-home points. There is no doubt that next-generation imaging, PET scans, whole-body MRI scans, right, are showing benefits in patients in the setting of biochemical recurrence. I don't think there's any doubt about that. However, the clinical priorities determine which examination you should perform first. Post-radiotherapy, prostate and the whole body is important. Post-prostatectomy, the whole body is more important, but depends on the pathological status of the local tumor bed. So you need to know what they did. Okay, so both of those are important. In general, you would do systemic restaging first, followed by local, generally speaking. But sometimes you may do it the other way around. So post-prostatectomy, if the PSA doubling time is slow, then you look down in the pelvis. Okay. In terms of the next generation technologies, there's no doubt that multiparametric MRI is the way to go in the prostate. PSMA is better than choline. Both of those techniques are probably more sensitive than whole body MRI, although whole body MRI is as good as choline for bone disease. Okay, so it's a bit subtle. Okay, and bone scans and CT scans are now much less recommended in the setting of biochemical recurrence, particularly when the PSA levels are less than 10 to 20. Okay, thank you very much.